Hello everyone, this is Dr. Pruett. Today we're going to continue our series on cardiology and discuss the 5 EKG findings that you can look for in your patients with syncope. Now this is definitely not an exhaustive list of all the things that cause syncope, but these are definitely some of the top 5 things I consider when I do have a patient who's complaining of fainting. Now, syncope is defined as a complete loss of postural tone that can be caused by a lot of things. And when in the big picture, I consider syncope, it's always easy to have a list of 5. I wonder if it could be caused by a problem in the head. Is this a vasovagal episode? Are they hypovolemic? Are they having a stroke or a TIA? Does this come from the heart? Is it some sort of palpitation or arrhythmia that was causing a temporary loss of perfusion to the head? How about the lungs? Did they get hypoxic? Is there some other problem in the lungs? Are they anemic? Is this a blood clot? Is there something going on in the hematology system? Or is this a volume issue, most notably dehydration? Now, these are my 5 causes that I think of for syncope. Today, obviously, since we're talking about 12 leads, we're going to be focusing on the heart. So with that said, anytime you have a syncope patient, it's going to be incredibly important to get an EKG because it could be the head or the lungs or the blood or volume, but it very easily could be the heart. And if you get that 12 lead and it looks okay and you evaluate for these 5 things we're going to talk about, you can move on to your other 4 causes of syncope and start to think about those as a potential cause. Now, an important thing here is I know we're very good at getting EKGs in elderly people or older folks with cardiac risk factors. But one of the lessons I hope you take away today is that even young people can have dangerous cardiac arrhythmias. And if they're complaining of syncope, it's very important, even in young patients, to make sure that you're getting 12 leads. And another very important takeaway about 12 leads is that, as my boss at Vanderbilt used to say, and one of my favorite mentors, he would always say the eye does not see what the mind does not know. So it's very important to always continue learning. Train your eyes to look for the big, bad, dangerous things that can cause life-threatening emergencies. And what I've found over the years is that the more and more EKGs you look at and the more you study, the more you're going to start to see, and the things will start to pop out as you stare at the picture of the 12 lead, which can be overwhelming at first. The more you look at it, the more detail you'll start to see, and you might be surprised what your mind is telling you. So these are going to be the 5 different life-threatening emergencies that we look for on 12 leads today in our patients with syncope. We're going to start with Wolff-Parkinson-White, which is kind of a form of SVT or reentrant tachycardias. We're going to evaluate the QT interval, which we've talked a little bit about before. Pulmonary embolism can definitely cause syncope, and we'll talk about some clues for finding or thinking about PE. We'll talk about a very interesting, little-known syndrome called Brugada. And then lastly, we'll talk about hypertrophic cardiomyopathy. Very important, we want to look at EKGs the same way every time. The more you have a systematic approach and you stick to the fundamentals, the safer you're going to be and the less prone you'll be to missing things. So I always start with, is it fast or is it slow? You'll see the EKG over there on the right side of the screen. This looks like a normal rhythm to me. Doesn't look fast, doesn't look slow. Is it narrow or is it wide? This one looks narrow to me. Is it regular or irregular? Pretty regular to me. I see P waves before every QRS, sinus rhythm. So right now we have regular sinus rhythm or normal sinus rhythm. Next, I look at intervals and axis. And the most important intervals for us in the field are going to be QT and QRS. We basically already evaluated our QRS when we asked ourselves, is it narrow or is it wide? So really when I'm thinking about intervals, I look at the QT, because if it's greater than 500, we know that this patient is at risk for spontaneous torsades, which can devolve into ventricular fibrillation, and it might affect the medications that I'm able to give. And then I look at axis, and this would just kind of be a hint to me of underlying cardiac disease. This axis looks normal. Remember, we look in 1 in AVF, and if the majority of the QRS vector is up in 1 in AVF, then we have a normal axis. And then lastly, I look for ischemia. So any ST segment changes, whether it's elevations or depression. Just quick reminder about the normal cardiac conduction system. The initial impulse for the heart to beat will come from the sinoatrial node up in the right atrium here. That will send a message via electrical signaling to the AV node, which is also at the base of the right atrium, go through the bundle of His to the right and left bundles, which then go to the Purkinje fibers and cause a ventricular contraction to send blood where it needs to go. So our first arrhythmia that we're going to talk about in syncope is Wolff-Parkinson-White, and this is a subtype of a supraventricular tachycardia. So supra means that it's coming from above the ventricles, right? And usually what happens in Wolff-Parkinson-White is there's some sort of physiologic bypass track around the AV node. So instead of a impulse coming from the sinoatrial node to the AV node and going through the normal conduction system, there's some sort of excess track somewhere above the ventricles that's also sending conduction. And if that conduction ends up going more through the bypass track than through the AV node, you can get an arrhythmia that's a little faster than it should be. Sometimes what happens in a normal heart is there's a tiny little pause after the signal is sent through the AV node to the ventricles so that the ventricles can fill and get ready to contract again. Whereas if you're going through a reentrant bypass track, there's not that pause and signals can be sent much faster. And so that's why it usually causes a narrow complex, because it's coming from the atria, but it's also tachycardia because it doesn't have that little pause there where it suspends the signal for a second. This tends to be more common in young males and females. You typically see it in younger people. They may present with palpitations, they may feel anxious or like their heart is racing, or even some pressure in their chest. And typically when your heart's racing, think about when you're running a race or your heart rate is elevated, you do get short of breath and you get a little sweaty, and it might be a little painful in their chest as well. So these are all common complaints with Wolff-Parkinson-White. Things that might help: you can attempt vagal maneuvers. You can also give adenosine. Remember, this is an SVT with any regular narrow complex supraventricular tachycardia. These are going to be your maneuvers. If they don't help, ultimately these patients may need ablation, which is basically just a fancy term for burning or scarring down this excess bypass track. And that's something that specialized cardiologists will be able to do in a physiology lab. So here's what a 12-lead would look like in a patient with Wolff-Parkinson-White. These are the things to look for, and we'll look at several so that your eyes can start to recognize and your mind will start to know what you're looking for here in the right patient setting. You're going to see a very short PR interval, so that's the distance between the P wave and the QRS. That's less than 0.12 seconds, really close, so they're basically touching each other. And really the giveaway for Wolff-Parkinson-White is going to be this slurring of the upstroke of the QRS complex, and that's called a delta wave. And if you look at this 12-lead, you can see it in a whole lot of leads, not just one. You'll start to see it everywhere. There's a little slurring of the upstroke here. You start to see it here. You definitely see it in V2, very clearly in V1, very clear in V3, V4, not so much in V5 or V6, but you can see it in several different leads. And it's not always the same lead. It just depends where that bypass track is located in this person's heart. Here's another 12 lead. So if we're looking for short PR intervals with delta waves, are you starting to see them? Okay, try to look at this 12 lead and see where you can identify the delta waves, and then I'll point them out to you. Okay, so we definitely have our short PR interval, but I can see delta waves here in lead 1, 2, maybe not so much in 3, AVR, AVL, or AVF, but you can really see them. And look at V1 here, V2, V3, V4, V5, kind of subtle in V6, but you can see it there as well. So those delta waves, that slurring of the upstroke, that's pretty pathognomonic for a Wolff-Parkinson-White. Here's another one. Take a quick look at this 12 lead, see what you see. I'm kind of giving you the answer since I'm telling you it's WPW, but I want you to start to burn these into your head. So what you see here again is a short PR interval. You can see a delta wave clearly here in lead 1, very clear in lead 2. I can't really see it in lead 3 or AVR, maybe subtle in AVL, and then a little more in the high lateral leads. You can see it too, V4, V5, V6. And here's just one more quick one. Again, the short PR, the slurring of the upstroke, you can see it. Once you see it in one lead, start to look a little closer at the others. Now, it's not going to change your treatment much. If you have a patient who's in SVT, you can ask them if they have a history of Wolff-Parkinson-White, because most patients will know and be able to tell you that they do. Initially, you can start with Valsalva because that's easy and you don't need to have an IV established or anything else. You can just have them blow against a closed glottis. Or there's this new trial that showed it's pretty effective as opposed to just your normal Valsalva maneuver, where you can have them sit up, blow against a syringe, which requires a lot of pressure, and then do that while they're sitting up. And then as soon as they stop, lay them down and elevate their feet. And that's going to give a really big rush of preload to their heart because you're sending all that venous blood back all at once. And sometimes that's very effective against SVT. The other thing we have in our toolbox is adenosine. Of course, you're going to need an IV, and you want this IV to be as close to the heart as possible because adenosine has such a short half-life and it's going to act very quickly. So you definitely want to have the patient on the monitor, potentially have the pads in place. This is going to make your patient feel very funny because essentially what you're doing is you're blocking that AV conduction for a second. You're literally stopping conduction, which is not going to feel right to your patient, and then resetting the heart. And you can start with 6 milligrams, you can go up to 12, and you want it to be rapid IV push followed by a saline flush because you want that to get to the heart as quick as possible. Now, one caution about giving adenosine, you definitely do not want to give it to anyone who is in atrial fibrillation, who has a history of WPW. If you see here, you can see those delta waves we talked about in V2, V3, and they'll probably be able to tell you that they have a history of WPW, but if you see this type of irregular AFib with RVR or any kind of wide complex tachycardia, do not give adenosine to this. Here's another patient with a history of WPW, but this is a wide complex tachycardia, which means we absolutely don't give adenosine. Even though you can see these delta waves here and they're telling you they have WPW, don't do it. Because what you can do when you give that medicine and you restart the heart is you can set them into VTAC or straight into VFib. So if you have an unstable patient with SVT, which in this situation I would define simply by hypotension associated with a fast heart rate. So this is a heart rate that's going too fast to not allow ventricular filling and is not able to sustain blood pressure. You want to synchronize cardiovert. So have the pads on, find your sync button on your life pack, make sure you have capture, and start at 100 joules. You can go up to 200, 300, and eventually 360. Now, a word of caution here. These are patients who we talked about are typically young, are typically male, and are going to have a very fast, narrow, complex tachycardia. SVT can look a whole lot like sinus tach at very fast rates. And so one thing I would caution you to ask your patient, if you can, or from the scene, gather information if this is potentially a stimulant overdose. So namely, cocaine and methamphetamine can cause a very similar looking cardiac picture, and adenosine or shocking is not necessarily going to work in those situations where you have sympathomimetic toxicity, because as opposed to SVT, which is a inherent cardiac conduction problem, a stimulant overdose is more of a sympathetic surge problem, where if they're in sympathetic overdrive, you're going to want to give, potentially just monitor, or consider giving benzos just to slow everything down. Whereas if you know there's an inherent cardiac conduction problem, you're going to want to use your more cardiac-centered tools, so adenosine or cardioversion if you need to. Just make sure you're always considering your entire clinical picture before you treat your patient. Number 2 of our things to look for in the EKG of our patients with syncope is you're going to evaluate the QT. And I know I've harped on this before, but in the pre-hospital setting and in the emergency setting, this is one of the most important things you can look at on a 12 lead, because it can be very dangerous, and the interventions that you can do can either make this better or worse. So the classic teaching when you're evaluating the QT is to look between the QRS complexes. So this interval right here, you have a QRS spike and a QRS spike. And in general, the rule of thumb is that the T wave should fall either in the middle or to the left of the midline, just like this. But that's very hard to see, and sometimes your eyes trick you. So I'll give you some more suggestions a little bit later. The other thing you can look for if the QT is extremely prolonged is that sometimes the T wave actually slurs into the next P wave, and that's called inappropriate touching. So you can see how close your T and your P wave are, and beware of that. These are all things that are visual, and like I said, your eyes can trick you, and this especially changes based on the patient's heart rate. So I'll give you some clues in just a second on how to do that a little bit more effectively and not get tricked. But first, let's talk about things that cause long QT. There's basically 3 main categories. I always think about electrolytes when someone has a long QT. So is somebody's potassium low? How about their magnesium or their calcium? Honestly, low potassium is one of the most common things we'll see. This happens very frequently in our alcoholics. It also happens in elderly people or people that are malnourished. And then very frequently it happens in our people who have been vomiting for a long time or are very dehydrated. So any patient who's dehydrated, dizzy, nausea, alcoholic, make sure you're getting a 12 lead and evaluate that QT, especially because we tend to give these patients Zofran, and Zofran can prolong the QT. I think about the antis. So there's certain antibiotics, certain antiemetics, antipsychotics, antiarrhythmics. If your patient is on any of the antis, make sure that you are getting a 12 lead before you treat them, because you can make that QT worse, and they are at risk for spontaneous torsades if their QTC is greater than 500. And I become pretty cautious about the medications I give if it's over 450. You can also consider the hypos, hypothermia, hypothyroid, and then hyporate, which is bradycardia, but this is one of the more common ones you'll definitely see in the field. If you have a bradycardic patient, make sure you're looking at that QT, because as everything starts to slow down and spread out in bradycardia, the QT is one of the things that does spread out in that situation. As I mentioned before, please think about the QT before you're giving Zofran, because Zofran can make that worse. And one of our most at-risk population for long QT is those that have been vomiting for a while and are hypokalemic. So before you give your treatment, make sure you're considering all of the effects that it could cause. This makes the inhaled isopropyl alcohol a very nice option to help your patient feel better while you're taking your time to get a 12 lead before you give them the Zofran and establish your IV. Okay, here's a look at a 12 lead. So we read them the same way every time. Is it fast? Is it slow? Is it narrow? Is it wide? Do I see a P wave before every QRS? And then finally we get to our axis and intervals. And here, if you look kind of between, just like we talked about, the R to R interval, it looks like this T wave is falling to the left of midline, right? But if you look up at the numbers, look at this. We have a QTC of 644. So that can be very deceiving when you're just using your eyes. Your eyes will trick you. So this is one of the situations I try to encourage people not to read the writing on the top until you've made your own diagnosis, and then see if you concur with what this writing says here. But I would absolutely encourage you to use these numbers that the computer gives you, because it's very good at this and they're very quantitative. You can look at your QRS and see, is it truly wide or is it truly narrow? And you can look at your QT, and that number 644 should make you feel a little bit nervous about your patient. And I would definitely not give them any Zofran, and maybe potentially even have the magnesium ready. We mentioned before that bradycardia can lengthen the QT. Look here, you see on this one the QT is 0.52 or greater than 500. So anytime that rate slows down, make sure you're evaluating the QT. Don't always rely on that R to R interval. As I mentioned before, long QTC can lead to torsades. This is a big danger, and you're at risk of spontaneous arrhythmia if you're over 500. The treatment for torsades is magnesium. You want to give 2 grams IV or IO push. Now, at the same time, torsades is not going to last very long. I'd say it lasts maybe 30 or 45 seconds. And so it very quickly devolves into VFib. So I would, as you're having one person get the magnesium ready, get ready to push that magnesium, I would also have the pads on the patient, because very quickly this is going to degenerate into ventricular fibrillation or VTAC, and you're going to need to be able to shock. So I would be doing both things simultaneously. All right, moving on to our third cause or third thing to think about in your patient with syncope, where EKG can be an important clue, is pulmonary embolus. And that's just a fancy word for big blood clot in the lungs. And if you look here, I think you've all seen this picture before, but here is a CAT scan. So you have the right lung here and the left lung here, and it's as if you're standing at the foot of the bed looking up at cross sections of the patient. You can see part of the heart here, and this is where the heart is sending blood through the pulmonary arteries. You have your right pulmonary artery right here, your left pulmonary artery right here. That's where the heart is sending deoxygenated blood to the lungs to pick up oxygen, where it can then return to the heart and get sent to the rest of the body. The problem here is that there's a massive blood clot completely occluding flow to the right pulmonary artery and to the left pulmonary artery. You see this big gray stretchy thing here. That's called a saddle embolus. And that is what can be deadly and causes a bad picture of obstructive shock. So people who are at risk for pulmonary embolism are those with a history of cancer. Cancer makes your body more prone to clotting. We call it coagulopathic. Smokers are at increased risk as well because they're in a constant state of inflammation. Extra estrogen has been shown to also increase clotting risk. That's birth control pills, any kind of pregnancy, even shortly after pregnancy, you have excess estrogen, or any sort of supplements. And then any recent hospitalizations or surgery where people are immobilized for a long period of time. This can even happen with, for instance, plane rides across the ocean or long car trips across the country. Anytime where your legs are not moving and blood is not flowing regularly. And then lastly, people can have a genetic predisposition to clotting as well. So you want to ask about all these 5 things and have a heightened degree of suspicion if they answer yes to any of these and are complaining of chest pain and shortness of breath. So the most common things that you're going to find on the EKG in your patients that do have pulmonary embolism, this is very hard to find, and none of these are specific for PE, but you put your whole clinical picture together, these are things that you want to look for. So sinus tachycardia is going to be the most common thing. Next, you're going to look for inverted T waves in your anterior lead, so that's V1, V2, V3. The textbooks will teach you about S1, Q3, T3. That's not always specific, but it's something you can look for. Honestly, I'm always more concerned about sinus tachycardia and the inverted T waves than I am S1, Q3, T3, because that happens very frequently and doesn't always mean PE. If you're starting to see right bundle branch block or ST elevation in AVR, this would suggest there's potentially a bigger clot and the patient is more at risk for cardiovascular collapse. Whereas smaller clots, or ones that are located more in the periphery of the lungs, can cause more sinus tachycardia and the inverted T waves. And as you progress to more signs of right-sided heart strain, this is going to suggest that you have a more dangerous clot. So if we look at our 12 lead for our folks with pulmonary embolism, here's what we see. You can see the S1, Q3, T3, and what I mean when you see that is S1, so you see a S wave. It's a big down spike right here in lead 1. Q3, which is the downward spike before the QRS in lead 3. And then T3, there's an inverted T wave in lead 3. So S1, Q3, T3. That's what that means. Again, not specific, kind of an incidental finding on many EKGs, does not always equal PE. What we see on this 12 lead though, and the patient that we know has a PE, is right axis deviation. So our vector is mostly down in lead 1, right? And mostly up in AVF. So which thumb do you have in the air? You have your right thumb up in the air, so that's right axis deviation. And our inverted anterior T waves, You can see a little more specific for PE. You can see peaked P waves as pressures are starting to build in that right side of the heart as they're pushing against bigger clots. And here's another 12 lead we look at with a known PE. Again, we see a big right axis deviation here. Remember, we're mostly vector down in lead 1, vector up in AVF. You look at your thumbs where they should both be pointing up. Here it's just right-sided. We see a very tall R wave in V1, which is another potential finding with a little bit of elevation in AVR, inverted anterior T waves, sinus tachycardia. All of these things are suggestive of PE. Here's another 12 lead of a patient we know had a PE. We see sinus tach. We see S1Q3 T3 again. We have peaked P waves in lead 2, ST elevation and AVR. These are all things you can look for. Pulmonary embolism, you need to have a high degree of suspicion because there's no one diagnosis on the 12 lead. There's just clues that could be what's happening. So again, we see sinus tach, we see inverted anterior T waves, we see S1Q3 T3. Really, what you want to take away from this is get a really good patient history. Do they have risk factors for PE, and are they clinically presenting like they have a PE? And if that's the case, then you can use your EKG to look for clues. So ask them about a history of cancer, truly any history of cancer, even if they tell you it's in remission. Any of your smokers are automatically at risk. Ask about birth control, ask about pregnancy, ask about supplements for extra estrogen, recent hospitalizations or surgeries, and any kind of genetic predisposition. Moving on, I doubt that many of you have heard about this, but if you catch it on a 12 lead, you might actually save a life one day, because guaranteed you'll probably see it at least once or twice in your career. And what makes this very important is that sometimes the 12 leads that we get in the field, as the patients are actually complaining of chest pain right now, these 12 leads are just a snapshot in time, and many times EMS 12 leads will catch things that the hospital won't, because you're there at the patient bedside when they're actively having their pain or having the trouble breathing, and your 12 lead might be very helpful in making this diagnosis. So what Brugada is a mutation in a cardiac sodium channel, and it changes the conduction through the cardiac electrical system, and can sometimes lead to fatal arrhythmias. And it's not always present. Some things make it manifest more than others, and typically fever or increased vagal tone or even alcohol can change the conduction through this system, make the mutation more manifest, and then cause symptoms or even cause sudden death. It's more typical in people in their 40s, more common in males and females, and it is more common in patients of Southeast Asian descent. And really, once it's identified on a 12 lead, the only treatment for it is an implantable defibrillator. There's 3 different types, but really I wouldn't worry about type 2 and type 3. Type 1 is the one I want you guys to look for. This is the most common and the most dangerous. And so the only thing you need to think about with Brugada, the only place you need to look, as opposed to all the normal 12 different vectors of the heart, you're just looking at lead V1, V2, and V3. So just looking in at V1, V2, V3, what you're going to see here is ST elevation that looks different than anything you've seen before. And it's kind of a coved pattern. See how it's kind of an upside down V in V1, V2. You're going to see a slight, it comes down the hill, kind of like a ski slope, but then it comes into this inverted T wave here, which looks different as well. And it's going to kind of look like a pseudo right bundle, right? You can almost see the rabbit ears starting to form there. What's this ST elevation, inverted T wave, pseudo right bundle pattern? And once that's burned into your head, you'll start to recognize it if and when you ever do see it. So here's another 12 lead. Again, just looking at V1, V2, V3. You see ST elevation that kind of catches your eye. You're going to see this downward kind of ski slope with an inverted T wave and a pseudo right bundle branch pattern. It's going to look the same way every time. And here's another look. Are you starting to see it? See how it doesn't look normal? V1, V2, V3. And your 40-year-old Southeast Asian male who's having palpitations or syncope, you're going to look here. You'll see your ST elevation with your T wave inversion and your pseudo right bundle branch pattern. And then lastly, as we're evaluating our syncope patient, one thing I'd like you to look for is hypertrophic cardiomyopathy. This is, again, going to be a young patient, and typically this is in the setting of exertion. So it's more common, unfortunately, in young athletes, specifically ones that suddenly collapse on an athletic field. It accounts for up to half of all sudden cardiac death patients in athletes. They're going to, before they collapse, they're going to be complaining of shortness of breath with exertion. They're going to have chest pain, especially that's worse during exercise. They may or may not have syncope. They may have palpitations, and sometimes you can hear a murmur if it's in the right setting. So there's an interesting article in NPR about this genetic cardiac disease. Hank Gaithers was a pro basketball player who actually collapsed and died of hypertrophic cardiomyopathy. He was born in 1967, had just been recruited to play in the NBA, very successful college basketball player, and unfortunately collapsed and died on the basketball court. This NPR article, it's called When Sudden Death Strikes Athletes. It's got a whole list of athletes, from basketball players to baseball players, football players, hockey players, who have all collapsed and died on the field due to this cardiac disorder. And essentially what it comes down to, remember, hypertrophy, the heart's just a muscle, and in this instance it's grown too big, and it's grown too big in a dangerous place, which is the septum right here. In normal heart, you can see that as the left ventricle sends blood out through the aorta, this muscle in the middle here that separates the ventricles is nice and thin. But in a hypertrophic heart, what happens is the left ventricle gets crowded. It can't fill as much, and if this muscle gets too big, it blocks the outflow of the aorta, and blood cannot get to the rest of the body. So you can imagine that if you have somebody in the middle of an athletic activity where they're potentially a little dehydrated, they're not going to have as much blood filling the left ventricle, so there won't be as much fluid in here to push out to the aorta. And if the septum is blocking the way and the ventricle is more collapsed than normal, you can see how you have an immediate cessation of blood flow. And here's what it looks like on autopsy. Again, this is a very large interventricular septum, almost completely occluding the outflow from the left ventricle. Here's what it looks like on 12 lead. The classic thing you're going to see is it's going to look like left ventricular hypertrophy, which is exactly what it is. So you're going to see big voltages where it's almost inappropriate touching of the QRS complexes, and then dagger-like Q waves. So you have big Q waves in the lateral leads and in the anterior leads, where that left side of the heart is really getting a close look, and there's just way too much muscle there. Here's another look at a hypertrophic cardiomyopathy heart. Again, you're going to have Q waves in the anterior leads, and it's going to look like left ventricular hypertrophy. Again, big voltages, nice big dagger-like Q waves in the anterior leads. Really, the clue to this is going to be a very healthy athlete who otherwise shouldn't be having chest pain or cardiovascular abnormalities on their 12 lead, and you're going to see signs of left ventricular hypertrophy or these dagger-like Q waves. So even in your healthy patients, you want to make sure you're still getting 12 leads if they're complaining of chest pain or syncope. So take-home points for today: when we think about syncope, make sure you're getting an EKG. You can evaluate for WPW, long QT, pulmonary embolism, Brugada, HOCM. Really what it comes down to is make sure you're getting a good history on your patients, because that's going to give you a clue as to what's going on. And don't discard young patients who are having syncope or chest pain, because they can have bad things too. Remember, you want to be getting a complete 12 lead, not just 4 leads, because that only gives you about 25% of the picture. And that's all I have. If you have questions, please reach out to your 7-8 or let me know. I'm happy to discuss.